Give me 1 second with these slides and I will get them shared as well.
Hi everyone. Welcome. We'll just give it another minute to let everybody join. Just a few more people coming in now. Just give it till 1 minute past. Hi everyone. Still quite a few people joining. I can see the numbers ticking up, so we'll just give it another 30 seconds or so, let everybody get in. Okay, I think we've steadied off a bit with the numbers, so we'll make a start. So, hi everyone, thanks ever so much for joining us this lunchtime on a hot day. It's my pleasure to welcome you to the latest Health Innovation Network Innovation Insight session. And today's session is titled Reducing High-Dose Opioid Harm Through a Co-Designed Patient-Centered Pathway. And it's going to focus on recent work here in the Northwest Coast region, which is also uncharacteristically hot and sunny today. So I'm Laura Boland. I'm Head of Evaluation at Health Innovation Northwest Coast, and we're one of the 15 health innovation networks that operate as the innovation arm of the NHS. So hopefully you've heard about the Health Innovation Network. And up here in Health Innovation Northwest Coast, we cover 2 ICBs. So that's Cheshire and Merseyside ICB, and also Lancs and South Cumbria, where much of the work I'm going to talk about today has happened. So I'm delighted to be chairing the session today and to be joined by some of our brilliant collaborators on this project. Lauren, if you could just move through to show the slide with the collaborators, that would be great, so you can see who's with us today. The next one, please. There we go. Everyone's nice faces. So joining us today, delighted to have Paul Hemsil, who is a lived experience patient representative and the prescription-only medication support lead for Cranstoun Derby. We've also got Katie Egan, who is Health Integrations Lead at Inspire Lancashire, and they are a local service who support people across Lancashire to take control of their relationship with drugs or alcohol. And Katie's role focuses on strengthening joined-up working across health and care services, with a particular interest in primary care, share care pathways and digital integration to improve access and outcomes for people using those services. We're also going to be joined by Jonathan Churchill, who is a pharmacist at Fleetwood Primary Care Network, which is up in Lancashire. Those of you who are not familiar with the area, Fleetwood is up near Blackpool on the Lancashire coast. And then last but not least, we have Faye Prescott, who was Medicines Optimisation Lead for Morecambe Bay and NHS Lancs and South Cumbria Integrated Care Board. So it's great to have everybody here lunchtime today. Thank you to you all for making time to join this webinar. And we're all here to talk about work that's been happening in the region to address the challenge of high-dose opioid prescribing in primary care for patients with non-cancer pain. So I'm hopeful that many of you on the call today will know that high-dose opioid prescribing is a public health concern, and it has been linked to challenges with dependency, overdose, side effects, and reduced functioning and increased hospitalizations. So something that really needs attention. And we now know as well that opioids are ineffective for long-term pain. And we recognise locally that national challenges around opioid prescribing are particularly acute in areas of Lancashire and South Cumbria, particularly along that Lancashire coastline. And so we've set out collectively to do something about it. Next slide, please, Lauren. So the agenda for today. We're going to talk you through how insights into the magnitude of the problem in the region has led us to come up with a way of supporting patients that's compassionate, that is evidence-informed, and that's grounded in what truly matters to those affected by opioid dependence. So you're going to hear from everyone today. Faye's going to talk us through the problem in the region and why we really felt that something needed to be done. Then we're going to hear from Paul, who will give you a patient's perspective and explain some of the issues facing patients today. I'm going to explain the approach we took at Health Innovation North West Coast with the evaluation of the pathway and the methodologies that were used. And then I will hand over to Jonathan, who will show you the actual pathway, who will walk us through it, how it worked in practice, how they selected patients and the support that they actually offered those patients to reduce their high doses of opioids. And Jonathan also talked you through the findings from the evaluation as well. And then finally, Katie will give her experience from the perspective of specialist services and the benefits that we found from working together across organisational boundaries. So once we've heard from everybody, we're going to make sure we've got plenty of time for a Q&A session. The Q&A should be open. So if we could just ask if you've got any questions as we go through the presentation, please pop them in there and not the chat, and we will keep an eye on that. We will endeavour to talk for about 30 to 35 minutes so that we've got plenty of time for questions, and we can follow up those and have a good discussion once the presentations are finished. However, we've got over 100 people on the call, which is amazing. So we will keep an eye on questions, and if we don't have enough time to get through all those that we get today on the webinar, we will make sure that we follow up with some FAQs after the session. So before I hand over to Faye and we hear about why this work was so necessary and why Lancashire and Fleetwood was exactly the right place to start it, I just want to acknowledge the role of the pharmaceutical company Camrest in this work, who funded Health Innovation North West Coast's involvement in the project through a joint working agreement and enabled us to do the evaluation and actually kick-started bringing us together to start these discussions about how we might tackle some of the challenges we were facing. Camrest were not involved in the co-design of the pathway or in the evaluation design, and the findings presented here are impartial and independent, but we remain thankful to them for supporting this project. So I will now hand over to Faye, who will tell you a bit more about why Fleetwood is a really deserving place to focus this work. Thanks, Faye.
Thank you very much, Laura, and good afternoon, everybody. So today we're really all proud here to reflect and celebrate the Medicines Awareness Pathway pilot, which was based at Fleetwood PCN, and for me to personally reflect for being a strategic ICB commissioner and my perspective on it. So some of you may know, back in 2021, NHS England launched the Opioid Medicines Safety Improvement Programme, driven by NHS England. And our goal as Medicines Optimisation team was simple but incredibly ambitious: to improve the lives of those living with chronic pain by reducing harm from long-term opioid use. It sounds so easy, but actually in practice, this is incredibly difficult. And what we found during that scoping is that actually there was no provision of a specialist drug and alcohol service into GP practices that would reduce the stigma for those that were more or less dependent or addicted to prescription medication. So that was one of the provision problems. I guess luckily for us, NHS England published in 2023 another document, which is listed there, a very long title, Optimising Personalised Care for People Prescribed Medicines Associated with Dependence and Withdrawal, which obviously includes opioids. And for those on the call that haven't heard, read or aware of this document, or you may have acted on it already, this is the time now to listen to the presenters and to review and reflect on what you're about to hear today from the guest speakers. If you haven't seen that document, seek it out, digest, reflect, look at your organisation's data, look at your local stakeholders in your local authority and services, and go forth and make change. It will be challenging. We are all in a state of flux and lack of funding to make change, but look at what can be done. Look at what resources you already have to improve things. So if we move on to the next slide. Why Fleetwood? As Laura's already touched on, we know areas of deprivation, those with high levels of illicit medication, and loads of high levels of illicit drugs, retirement towns with a high population of the elderly who are in chronic pain, And
Sorry, Faye,
those,
to cut across you. Lauren, can you reshare? We can't see Faye's graph, and I think it's really
2 seconds,
helpful.
just
The
having a bit of a
slides
tech
have gone.
issue. Just having a tech issue.
Sorry,
It will be
Faye.
right back.
that's no
Brilliant.
problem. I'm prepared to talk over until we get the IT issue sorted. So that's no problem. So we know that all of those things contribute to actually a high level of prescription opioids being prescribed. So for those that are presenting today, I'd like to say thank you very much. And the reason why we chose Fleetwood is that it's one of the highest places for prescription-only medicines in terms of volume of opioids that's issued within that area through prescriptions, but also the high volume of high doses, combined with the deprivation and high level of illicit drug use within that locality. This is why we wanted to focus particularly at Fleetwood PCN to reduce the risk to the prescribers prescribing the medication, but also to that local population. So there's a call of reflection here. Please reflect post-event at what you're about to hear, because every prescription reviewed represents a conversation. Every dose reduction done safely and in a biopsychosocial model with the patient engaged represents a safer future. And every life improved reminds us of why we've done this work collaboratively together and the success of it. So I'll now pass you back to Laura. Thank you very much for sorting out the IT. Thank you, Laura.
Thanks, Faye, and thanks, Lauren, for sorting slides out. Yeah, and absolutely, it's troubling data and it's difficult times, but I think that's all the more reason that we take action to address these issues. So thank you for setting that scene. Now I'm going to hand over to Paul, who's going to give the patient perspective and share insights as a representative with lived experience. Thanks, Paul.
Thanks, Laura. Good afternoon, everyone. I'm Paul Hemsil. I'm the founder of POMS, Prescription-Only Medication Support, which I founded back just after we came out of lockdown in the county of Derbyshire. It was a voluntary pilot approached by public health in this area because they were getting approached by a lot of GP surgeries that were, struggling to find the correct support because treatment services in this area and the city weren't commissioned to provide that support. So my journey is I was an operations manager in manufacturing, a company I worked for 26 years. Grew up from a loving family home, no trauma, back injury, got put on all the Medicare, every opioid, gabapentinoids, benzos and Z drugs in the end. And it, of course, cost me my career, my relationship and almost my life due to accidental overdose a few times, but also attempting in the end to do it myself because I felt let down by a system that I paid into all my working life that couldn't help me when I needed it the most. So I now run POMS for Derby City, for Cranstoun treatment services. I'm a lived experienced advisory board partner for addiction professionals. I'm a trustee for the charity PAIN, which was set up jointly with Professor Yasser Abbasi and Catherine Kemp, a journalist and author who also had lived experience. And I set a support group up online about 4 years ago, I think it was now, called Painkiller Addiction Support UK. And there's close on 1,000 people on that up and down the UK now. So, yeah. Next slide, please. So this was an NHS England headline from March 2023. And the headline states, the links on there is out in the public domain, almost 500,000 fewer prescriptions between 2009 to 2023 as the NHS continues to crack down on potentially addictive medicines. So I looked at this and I thought, I get it, I agree with it, but how have you done it? And are there any consequences for doing this? So I looked at this and I found this chart and it shows that from 2009 up to 2018, the average of over-the-counter analgesia throughout the UK averaged £550 million a year in sales. From 2019 to 2025, that average is now increased to 744 million and it continues increasing. So the timing, I think, warrants further investigation as, yes, we're all for deprescribing, but it needs to be done safely, appropriately, in the correct way with the right support for patients. Otherwise, they might divert to other more harmful options. Next slide, please. And this just shows you that graph. There's a link on there to look at that graph for yourselves. You can see pretty stagnant up to you know, that particular year, and then the sales just increase. Next slide, please. The other side of that is online purchasing. People believe that it's the deep dark web. It isn't. You can get this stuff anywhere now. You only need to, you know, to Google it. This is just I send this stuff away all the time from patients that are referred in to me. People off my support group send me this stuff to get it tested that they've bought online or off the streets, and they are fake, and you cannot tell. You just cannot tell the difference. And there's a big issue now with online purchasing that are laced with nitazines, xylazine. There's a new synthetic opioid out now, cyclophene, which is responsible for 4 deaths in December in London from 4 fake OxyContin pills that killed 4 people. Nitazines were first synthesized in the 1950s by Swiss pharmaceutical companies, an alternative to morphine, but it got shelved because of the potency of it. A lot of this stuff, the weakest nitazine that I've seen in a fake pill is metanitazine, which is 50 times stronger than heroin. And bromomesalam is also in that as well. Sometimes there's loads of other, not just synthetic opioids, but other nasties in there as well. Bromomesalam can be 10 times stronger than diazepam, milligram for milligram. And I once recently sent a fake diazepam to be tested that came back with pure bromomesalam. And thankfully, this person was fortunate that it wasn't always what they usually find, which is metanitazine as well, because this is what's killing people now. This is just an example of a few. This presentation I'm giving you now, due to time restraints, is a big part of a much bigger presentation that if anyone wants to discuss further, please reach out and I can share that with you. Next slide, please. So what happens when opioid reduction outpaces patient readiness? This is important because supported deprescribing shows. I always use, when I set POMS up, I wanted it to, there wasn't any such service that existed for me. And I knew it wasn't just in my area, it was UK wide. And this is why I set POMS up, to fill that gap. So it has to be person centered. It has to be when the patient's ready, we need to give them that information. And it's not just a case of reducing by 10% every 2 to 4 weeks, away you go, I'll see you next month for another reduction. It doesn't always work that way, and quite often it fails. So this just shows the difference between supported and unsupported. I'm seeing patients on a daily basis now that may have attempted to reduce before and they've failed, and they've come to me and we'll work out a slow reduction plan. And it is wraparound care and support. It's not just about reducing the medication, it's about what else is going on in the life. And it's that old adage of holistic approach, but it really is vital, along with wraparound, you know, psychosocial intervention as well, what else is going on. So I've always said deprescribing itself is not the issue, but unsupported or overly rapid deprescribing may create unintended harms, which I'm seeing that a lot as well. Next slide, please. So good deprescribing looks like patient readiness. Patients have got to be ready, but even those that aren't, I get them in. I've been told off for this before, but on a first initial one-to-one with POMS, I always allowed 2 hours out of my diary because we have to get to know the person. It's not just a patient, it's a person. Know why they were started on it, what else is going on in their life, like I've said, and they have to be ready. If they're not, then I always give them that. I share a presentation, that everything that happened to me, not to frighten them, but just explain that this happened to me. These are the consequences, both physically and mentally, of the medication over time. And bearing in mind, I was addicted to this stuff. A lot of these patients may not be addicted. There is a difference between dependence and addiction. And it's important to understand what that difference is. So I then give them the information to read through, to take away with them. I do a follow-up call in 2 weeks. And a lot of them will come back and see me, want to agree to a slow reduction plan, which I'll work out with them and liaise with the GP, you know, on post-dated weekly scripts and that type of stuff. And it's always done at that patient's pace. Person-centered wraparound care and support. Language used. Language is vital. It has to be approached in the correct way because otherwise they'll just switch off. And this is why the word deprescribing will scare a lot of people as well. And I think this is where, I think you'll correct me, Laura, but this is where the maps came up, where we said it should be medication awareness. So shared decision making is vital. Individualized plan and pacing, because again, this 10% every 2 to 4 weeks, it has to be person centered. It depends on the person. We all metabolize this stuff differently. It depends on the dose, what they're on, how long they've been on it. You know, are they polypharmacy users, or are they on more than one? But all this has to be taken into account. Withdrawal management, psychosocial support, and ongoing reviews. As I say there, the objective should be better patient outcomes, not simply fewer prescriptions. Next slide, please. So recommendations, I think we need to recognise prescribed and over-the-counter dependence as a distinct treatment need. We need improved support and awareness around deprescribing, develop and roll out national referral pathways for prescribed medication dependence, expand specialist medication support service nationally. When I set this up, it was my dream not just to do it in the city or the county where I'm from, but I needed POMS to be nationwide, because I knew there was many hundreds of thousands of people out there that found themselves in my position, that were lost, lonely, didn't know where to go, being turned away by the very same system, one that put them there, and two that couldn't help them when they needed it the most. And obviously improve national data collection, because there's data in there around over the counter, which I've just shown you, but the paracetamol and the ibuprofen damage that this is causing people when they're trying to just get the codeine to prevent withdrawal, we need better data collection, because if someone's in, I think there's 100,000 A&E attendances through paracetamol overdose a year, there's 50,000 hospital admissions, but that doesn't differentiate between what is intentional harm and what is harm caused by over-the-counter analgesia, just trying to get the codeine to prevent withdrawal, not being aware it's the ibuprofen and the paracetamol that's going to do the damage. Last slide, please. Next slide. So key conclusions to wrap up: reducing harmful prescribing does matter, obviously. Over-the-counter codeine dependence remains under-recognised. Hidden harms from paracetamol, ibuprofen are substantial. POMS may be identified an unmet national treatment gap. Correctly supported deprescribing reduces harm. The question is not whether deprescribing should happen, but how we do it safely. Thank you.
Thank you, Paul. And I just want to say thank you for all of your input into this project. You're always really open and generous about your experience, and not only is it really appreciated, but it was so important in this work in co-designing something that really touches patients and offers what they need in that non-judgmental way. And you know, we couldn't have done it without you. So thank you again, as always, for participating. So you've got me for a couple of minutes now. I'm just going to explain a bit more about Health Innovation North West Coast and our role and the evaluation team's role in the project. So if we could have the next slide, please, Lauren. Thanks. So just to explain then, what do we actually do? So Health Innovation North West Coast played that role in stakeholder convening and bringing everyone together in regular steering group meetings, and then a series of co-design sessions so that we could come up with a solution and a better way of responding to these challenges in the system. And that produced a new pathway, which we're going to talk you through, and it was very much a shared care pathway. And then once we've managed to stand up the pathway and it was live, then Health Innovation North West Coast then led on that evaluation. So it wasn't just me, it was my wonderful colleagues, Paul Brain and Sarah Whittle, that worked on the evaluation, and then also our communications manager, Karen Huff, who I think is on the call today as well. So huge thanks to all those for their contributions. And then obviously, it was a collaborative effort. So the PCN pharmacist, Jonathan, and Faye and the ICB medicine optimization team agreed the approach to the structured medication reviews and thought through the safety governance and how we would manage taper protocols. And then the PCN very carefully selected patients who would be suitable to contact and invite in for support. And using all the insights from Paul, made sure that we used the right language for that, and that we were being as open and non-judgmental and stigmatizing as possible in bringing those into the process. And then we also had the support of Inspire Lancashire for that work. So they employ an excellent wellbeing practitioner, Rebecca, who's, I don't think, is with us today, but she was linked in to provide that psychosocial offer and ensure continuity of support beyond the medication changes. And then together we managed to create this place-based biopsychosocial approach to reducing harm from high-dose opioids and polypharmacy, focusing on chronic non-cancer pain. Next slide, please, Lauren. So our team at Health Innovation North West Coast conducted the independent evaluation into the pathway, and the primary aim of that was to understand essentially whether this new pathway leads to a safe reduction in opioid prescribing for those patients that were currently on high doses. But there were some secondary aims as well. So we also evaluated whether the pathway delivered a positive experience for patients and staff, and including whether patients stayed stable during those medication reductions. And we also sought to understand whether it was acceptable to all the healthcare professionals delivering it, and whether there were any barriers to further spread across the ICB and beyond. Just to clarify, in the patient cohort that were eligible for invitation to have a medication review were those that were on high doses, and we categorised that as over 80 milligrams. And it could be one opioid, or it could have been a combination of multiple opioids. And overall, then the proposed goal was to improve outcomes for patients on high dose opioid medications that were at risk of dependency, potentially already dependent, through testing the pathway and surfacing barriers and facilitators to further spread. And so that's really just summarising the evaluation goals at high level. It's just the headlines today, but we'll follow up with a link, but there's a full evaluation report, a comprehensive report with all the findings in, which you can find on the Health Innovation North West Coast website, and we can share a link to that as well with the slide deck by way of follow-up. So I'll just talk you through it in a bit more detail about the methodology. Next slide, please, Lauren. So these were the things that we actually did with the evaluation. So the clinicians were surveyed at the start of the initial 6-month pilot. So we actually stood the pilot up in January 2025, and we collected data until June 2025, so 6 months worth of data. And clinicians were surveyed at the start and the end of that period using something called the theoretical framework of acceptability, which is a well-validated implementation science tool that we use fairly regularly because it gives us a nice balanced measure of clinician perception across these domains that you see there. So effective attitudes are overall, do they like it? What's the burden, the additional burden of doing this work in this way? The perceived effectiveness, any ethical issues, intervention coherence, so that is, does it make sense? Are there any sort of outstanding concerns? And then also looking as well at the opportunity costs. If you're doing this, what are you not doing instead? And how easy it is for people to carry this on and do it themselves. We had a patient experience questionnaire that we asked patients who had engaged with the process, so not just those that had a medication reduction, but all those that engaged in the process to find out whether the pathway was delivering a positive experience and whether we could learn anything from the interactions with the healthcare professionals. At the end of the pilot period, we did a focus group where we really focused on any outstanding barriers and actually what were those drivers, what were the broader benefits, and any additional challenges that we needed to overcome before we could get to this point where we're actually making recommendations for further spread. And then obviously we looked at quantitative data as well, so as well as medication review referral rates and review uptake rates. Obviously, we looked at that change in opioid medication dose as the key things, and also looked as well at other elements of the psychosocial model offer. So uptake with social prescribers, rates of referral to the drug and alcohol team as well. So hopefully Jonathan has joined us now, and he can talk to the pathway itself and the findings. Have we got Jonathan with us yet?
I
know you're
Hi,
having to
questions. Can you hear me?
I'm so glad you can make us. Yeah, I know
I'm
you're
really sorry I was so late
frontline busy
today.
day. So thanks ever so much for joining us. I know it's a challenge when we're out here living this and doing it. So hi, Jonathan, if you're okay to take us through the pathway, that would be amazing.
Absolutely. So obviously on the slide you can see, so basically patients were invited who were on above 80 milligrams of morphine a day into a structured medication review with myself initially. Those who were sort of displaying more sort of maybe some dependency issues, maybe kind of ordering medications early for multiple reasons, you know, bottles of morphine smashed, that sort of thing. We'd maybe try a bit more of an intensive intervention, maybe actively call these sorts of patients. Also patients that were not necessarily on more than 80 milligrams of morphine a day, but were displaying these sort of behaviors that could suggest that they had maybe a bit of an addiction issue going on as part of the regime. So it was essentially having a structured medication review first, going through our pain review template that I made on EMIS, obviously reviewing the pain, what they were taking, doing pharmacological and non-pharmacological options. Are they under physio? Were they trying things like TENS machines, swimming, graded activity, these kind of things? Referring to the 10 steps to live well with pain. Unfortunately, we live in a bit of a black spot in this area. We don't have pain clinics. We have pain clinics at the hospital, but their waiting lists are very long. Some peer support groups, but again, they're Blackpools. They're 10 miles away, nothing local. So we would try and give as much support as we could here at the practice. And for those patients who were maybe displaying some sort of dependency or addiction as well, we would offer a referral into Rebecca to do the more intensive psychosocial support. And she would often see patients either on telephone at the surgery as well, so not necessarily reviewing her at the Inspire service per se. So they weren't being seen as, they weren't seeing in the drug and alcohol support service. So they were getting that support, but without actually having to physically go to the building, to kind of reduce that sort of judgment and judgmental aspect. So they felt able to kind of open up and talk a bit more about their issues. And obviously for those who didn't engage with the service, we initially didn't look to enforce reductions, but now that we've run this service for several years now, obviously there will be some patients that we are now starting to enforce, but that was very much a last case resort, because obviously we appreciate enforcing people on high dose can actually trigger further opiate abuse sometimes in certain patients when they are struggling with addiction alongside pain and other things like that. So we don't we don't want to enforce and ultimately make that patient more ill and have worse outcomes essentially. Next slide, please. Okay, so this is the outcomes of the pathway. So we ran it over a few months at one of the doctor's surgeries here in Fleetwood, on a Wednesday morning, over a few months. So about 51 patients were identified, about 30 people engaged with the pathway, and of those people that engaged, our average reduction was about 33% in their opiate prescription. I think I calculated I reduced it by about 1,300 milligrams of opiate morphine equivalents prescribing per month at the surgery, just in that short time. And I had 3 or 4 clinics on a Wednesday morning at one surgery. So for not much extra time, we were able to really make a real significant reduction in the opiate prescribing at the practice, and the feedback came from the forums, came back really well, actually. A lot of very positive feedback. They were really glad that they were able to reduce nice and slowly at their pace. We didn't rush, we didn't force anybody. A few people, I think there was the only kind of real negatives is as people were lost to follow-up, certain patients, but those patients were rung and they didn't return the call. So, at the end of the day, the patients could always, ring the surgery and book a further appointment if they wanted to. Okay, next slide. Is this Kate?
That's Katie's now, yeah. That's you done, Jonathan, unless there's anything else you wanted to share.
No, I think we're okay for now, but obviously if we could, if anyone's got any questions at the end, I'm more than happy to take any.
Brilliant, thank you. And I don't know if you noticed while you were talking, but you've had lots of applause popping up
I do
and
appreciate
parts.
that.
Yeah,
Thank
so
you.
I think that's acknowledgement that it's not easy to do. In 6 months you had a real significant impact on your cohort of patients, and whereas other interventions haven't seen anything like those figures. It is small, but it has real potential if it's scaled across regions to have a huge impact
And
on this cohort of patients.
I think a lot of people are very worried because it's a very difficult conversation to have with people, and I think that naturally makes people avoid it a little bit sometimes, and it's really good to have that separate time slot to have these sort of conversations, because it really prepares you as a practitioner as well, and it gives patients that time so they can open up at their own pace as well.
Yeah, absolutely. Well done. And then finally, we're just going to hear from Katie now, who's going to tell us that perspective from specialist services, how they get involved, and why, and what maybe it wasn't traditionally their area of work, why it's been so important, and why it's then suitable for spread across more of their primary care partners in Lancashire.
Thanks, Laura. And just before I talk about what we did, I just wanted to explain why we were there at all, because, I imagine some of you that's probably not obvious as a commissioned drug and alcohol service, because our work supports people who are addressing illicit drug use and alcohol problems, right? But the problems we support, they just don't fit into those neat boxes. And the data we collect tells a story of people with complex relationships across a range of mood-altering substances, including prescribed medications. And we knew that we had a fragmented system where people were passed from one door to another, and most often just falling through the gaps. And we also have in Lancashire, and I think nationally, a drug and alcohol related deaths panel. And within that panel, the group started to collect data from coroners. And what the coroners started to give us isn't just cause of death data, but from toxicology reports, they started sharing information around implicated substances in toxicology results. And what that gave us was a clear indication that high-dose opioid prescribing and pregabalin actually they were quickly identified as key risk factors in the drug-related deaths that we were looking at. We knew we needed a structured system-wide approach, and we wanted to help shape it because the interlink between prescribed and illicit drug use, it's irrelevant to the person at risk of harm through high-dose prescribing. Can I have the next slide, please? So what we could bring to this work was, I guess, specialist experience and knowledge. Our practitioners, they are trained in use of motivational interviewing, trauma-informed practice. They know how to do pacing. They're used to working with resistance and using techniques to help people move through the fear and hesitancy associated that. But we're also very experienced at working alongside clinical plans, because as a service, we have clinicians, we prescribe, and we have a lot of experience in working with people who are reducing what we prescribe them. And it helped create a culture of teamwork with the person at the heart of that decision making. So we sat us alongside someone who, when they were frightened about reducing prescription they've been on for years, we made sure that conversation happened in a context of trust. And we worked with the person's priorities and life factors. So we were able to take time understanding what their history was with prescribing, their fears, what else was happening in their life. And we worked with the person together with the pharmacist. And this combination, it just made safe tapering possible, I think, in a way that celebrated every step and reduced disengagement. And critically, I want to say, when someone's opioid dose did reduce, we stayed with them for as long as they needed it. And that continuity, the relationship that outlasted that medication tapering process, it helped people adjust to showing up differently in their lives while having a kind of safety net for any wobbles. we know as a specialist addiction service that back end care, it's a core part of what we do in addiction service, and we call it recovery support. And the reason we do it is because we've got decades of evidence that tells us that in our world, that part of the model's critical if you want to help somebody to achieve sustained change. Can I have the next slide, please? So to bring, excuse me, to bring this to life, I just wanted to share this quick anonymised example of what actually happened to somebody in Fleetwood who engaged on the MAPS programme. Jane is a pseudonym, but she'd been on opioid medication for a long time. The pharmacist, Jonathan, got in touch and spoke to her about the possibility of reducing, and she was actually quite open to that, and she'd been thinking about it herself, but she was finding prescription management stressful, especially things like weekends and renewed prescription times. And her anxiety about staying on the medication was growing too. She was getting older. She wasn't daft. She understood that with age, some risks increase. So what the MAPS brought into the picture was it added that layer of psychosocial support alongside the medication plan. So when Jonathan introduced it, Jane talked about feeling tied to the house, for instance, and worrying that her pain or anxiety might get worse as she went out. Our worker then, that's where we started. We focused on building her confidence and her coping strategies and some everyday routines to sit alongside the clinical work that Jonathan was doing. And our practitioner, Rebecca, she worked with her at a really gentle pace. They focused on what Jane wanted to change day to day and started small, simple, achievable activities at home. They started to make tracks, and a real turning point came when Jane rediscovered a love of crystal art. She described it as bringing back a sense of calm and purpose into her life, and her confidence grew. They started looking at reconnecting with the community, and she actually found a couple of local art groups in Fleetwood. And over time, she said that being creative, it helped soften the edges of her pain and it reduced her anxiety. And eventually she felt confident enough to stop opioid medication altogether, trusting the coping strategies she's built and her new sense of identity. And now she's even exploring other groups and thinking about volunteering. And that for us is what we take from this in terms of all the work that we put into co-designing this model with everybody's specialism and their voice as part of that process. Can I have slide 4, please? Next slide, sorry. So I want to close with what we're asking you to do with this. And I'll take the drug service side, and then Faye, who you've already heard from, will just share some thoughts around the ICB view. So from Inspire's perspective, and I have to say, Inspire is the local name for our drug and alcohol service, and our organisation is a national charity called Change, Grow, Live. You can see that logo in my background. But from our perspective, there's 3 things that are perhaps really important for us. We want to extend MAPS in other parts of Lancashire and beyond. We think the model's ready. We're not asking anyone to design something from scratch. And second, we have that commitment to protect that practitioner role to test this in other areas as well. What we want to say is when budgets are under pressure, the psychosocial element is the piece most at risk of being cut. It's also the piece that makes everything else work. And for the drug services in this room, you don't have to wait for results. You've got clients on opioids. And what we're doing is flagging them as a priority for review and starting to work with primary care networks on how we can differently support those people. Faye?
Thank you very much, Katie. Yeah, so on reflection, I think it was really invaluable about the drug-related deaths. data. I know that that's been fed down to the local team within our ICB to start engaging those conversations with clinicians on the ground about the safety of those medications in combination, but particularly pregabalin and the risk of abuse, addiction and dependence on that. So that was one of the first points. The second point, embedded the biopsychosocial model review as standard. That's key. And I think what we need to recognise is that resources are tight. So we need kind of like a bit of a pyramid model dependent on that individual about what that biopsychosocial model looks like for that individuals. You may have individuals that will quite happily engage in the process. You may get some people more fearful, whereby a service like we've just described and a review like we've just described will be more beneficial. So it's about commissioners thinking about that and looking at the resources to fund that and where it's needed. And shared learning across the areas. I mean, Jonathan highlighted about there isn't really much support out there in some geographical locations, and we as an ICB are working with PCNs and certain localities in looking at integrating more pain cafes, because we need a tiered support process to help individuals. So that's another thing we're taking forward. So they're the main three things. So thank you, Katie, for putting those on a slide deck, because yeah, I'm in complete agreement with you there.
Thank you both. Thank you for closing out our presentation with such important points, and hopefully everyone's got some food for thought to take away with today. I've been trying to keep my eye on the chat, some lovely comments coming in, so we appreciate those. And also requests for the slides. So yes, definitely we'll share those to follow up. And as I said, there's links in there. So not only is it the full evaluation report, but we've also got some short case study videos. So if you want to share this back with your teams, you want to remind yourself what you've heard, that video is essentially a summarized version of what we've talked about today. So it's a really nice way to get additional attention on this and hopefully get things moving in your region. Okay, I'm really keen to have a look at the Q&A. We've just got 12 minutes or so left. I know some of the team have been trying to capture and respond to questions on the chat, so hopefully we're covered there, but we'll start with the ones that are in the Q&A and sort of see where we get to. So the first one in the chat is around the cost effectiveness evidence. So saying that alongside the qualitative aspect, yes, we've got quantitative data. So we've looked at the reduction in prescriptions. We haven't fully costed that. Obviously, the reduction in prescriptions themselves are not the important saving here. It's actually what it means for the patients in terms of quality of life, hospitalisation, follow-up visits, etc. What we're hoping to do at some stage in the future is to scale this and hopefully then get some data where we can start to attach some costs to that. But it's not something that we've done yet, but absolutely we see how important it is. There was a question there, I don't know, maybe Jonathan, this might be one for you. So were pharmacy technicians utilised in any of this, and do you think there could be a role for them?
Yeah, I mean, they helped us definitely to do a lot of the EMIS searches and pulling the data and having that sort of initial chat and and arranging those appointments and that sort of thing. But definitely technicians, if they wanted to upskill, could definitely if they felt comfortable to do a lot of the conversations around the opioid reduction. There are other models in other areas where that conversation is largely done either by a CWET worker from a drug and alcohol service or a technician, and then the pharmacist just does the change in prescription and the dose reduction. And that's something to consider if you did want to scale it up, particularly you had a particular large cohort of patients you wanted to deal with, and of course pharmacist time can be time precious as well, so it's another way of expanding it to expanding the service to the people who ultimately need it.
Thanks, Jonathan. Faye, do you want to come in on that one as well?
Yeah, very briefly. Yeah, I think pharmacy technicians, I think it's about having the skills that Jonathan has just mentioned. That we had a wonderful Rebecca, who worked with Jonathan, that was part of the Change, Grow and Live, didn't we? And they're trained in like the biopsychosocial model and trauma-informed training. And I think they're the types of training where pharmacy technicians could undertake, and perhaps possibly a bit of like a mutual agreement could be taken place with drug and alcohol teams and PCNs or a GP practice, because I think it is about what workforce have we got out there and how to effectively utilise them, and what resources and what providers got that could help train up other members of staff. That's a kind of a big pie in the sky kind of thought from me, but I think in the future that's what we should probably look at doing.
Yeah, that's a great suggestion, Faye, and it really came out in the focus group. You know, the strength of the collaboration and learning from each other, and that skill mix and skill sharing was critical and is of real value. So as much as you can do with that, the better. Well, we've got you, Faye. I don't know whether you can comment on the next one as well. So how do we come up with that patient cohort dose of over 80 milligrams or on multiple opioids?
Yeah, it kind of like was a local one, but actually the Faculty of Pain have updated their guidance, so I've put that in the chat for Joanne and others just to for clarification on it. That has actually been reduced down even further with an ideal target of 15 milligrams per day. So, you know, they are getting a bit more, you know, looking at this in a bit more detail. And I also wanted to make a point that Paul mentioned, and I think this is key as well, because we're talking about reducing people's opioids here, but actually also what we need to really bear in mind is the initiation. And I know from talking to Paul and others within kind of like this forum, is that patients really do need to be informed about the side effects and the risks of opioids, and for them to be reviewed at the very beginning, very regularly, and to be tapered off as soon as that acute pain is completed. So, you know, that's just something to bear in mind, because we can tackle a problem over here, which is reducing them, but why did they get there in the first place? Let's go down a bit downstream and prevent people from dose escalations up, and embrace that biopsychosocial model way before a dose escalation occurs and that harm can arise. So I just thought I'd touch on that point, Paul, because that's something that I took away when you were going through your presentation before.
Yeah, thanks.
Yeah, thanks. Yeah,
John.
It is. Go on, Jonathan.
Sorry, Jonathan wants to come in as well, Paul, but then we come back to you.
I was just making the point there, sort of following on from what Faye said, was that, you know, when we were looking at the open prescribing data and the EPAC data for that surgery, I was expecting a massive reduction in the opiate prescribing at the Mount View practice, but unfortunately there actually wasn't. Now, whether that's because obviously the data can take months to kind of ultimately filter through, because we did actually notice towards the end of the year after the project was concluded that actually, yes, there was a significant reduction in opiates, but obviously, you know, it obviously if more and more people are started on them, even at lower doses, it will skew the data, and it will feel quite disheartening because you've done all this work and then you look at the graphs and nothing's really changed to any sort of statistically significant degree on the overall prescribing data. So something to bear in mind, like Faye's saying, it isn't just about getting the high dose off, it's counselling people on opiates to make sure they understand from day one, and, you know, making sure that for a lot of people it is just a short course and getting them off before we continue these prescriptions infinitum.
Thanks, Jonathan. Okay, there's lots of questions around sort of, is it funded yet? Who's funded the work today? Is it sort of commissioned? So we might need to come at this from a collective for Faye. I don't know if you want to come in first.
Yeah, I think it's all been done on goodwill, Katie. Has Katie put in her slides? They weren't commissioned. And I think that's one of the huge challenges with this. And that's why you need to work collaboratively in terms of the funding and the resource that's available. Because, you know, at the end of the day, we should be looking at the patient population and their needs rather than, well, actually, who's going to fund it? And it's very difficult to have those conversations. So I'm incredibly grateful for Katie and her skill set in getting the movers and shakers within her organisation to engage. And and hopefully in time we'll be able to possibly fund some of this, but it's just incredibly challenging at the moment with the funding.
Katie.
Yeah, and I just wanted to add to that as well, because I know there's some questions around this in the chat. So we were fortunate in Lancashire in that our commissioners, the commissioners that pay for the drug and alcohol services, were very much in support of this. What we recognised really is this is a core part of prevention. So we know that NICE guidelines change for the thresholds of prescribing. We know that the risk was there, but we also knew that there was a risk if we didn't get involved, that there may be unintended consequences of, you know, we talk about rapid deprescribing and people moving to sort of buying via the internet or other means. So we wanted to be part of this conversation because we wanted to be part of preventing that from happening. And I think that it also speaks to a question about Jonathan having extra training. We did a lot of work when we were designing this model around language, around how to have conversations with people. And on the slide that Jonathan shared, there was something around the professionals and how they found this process as well, as a result of the fact that we were sharing our knowledge and expertise and learning from each other as we went along.
And I think it's safe to say the take home is we would love this to be formally recognised and funded and spread at scale. So, you know, any conversations you can have in your locality with your teams to support that would be great. You know, it'd be great across Inspire. Katie gives recognition that, you know, this is absolutely the way that you should be working with every PCN. So I think we've got time for one final question. There's a question in the chat around over-the-counter sales of opioids. I don't know whether there's any data around that we can talk to around increased use due to internet pharmacies and online providers. Or Paul, I know you presented the trend, but I think maybe we're not entirely sure of what's going on behind that, but maybe multifactorial. Is that fair?
Yeah, it does. It does. When I looked into this, when I was doing all the research, I wanted to make sure that it did allow for inflation. So it showed, you know, a trend in increased items sales. So it does say, if you click on the link that I provided in the slide, it does say on there that it did take inflation into account. And I'm getting it with POMS referrals, it's getting a more common theme now. I don't know if anyone saw it a couple of weeks ago. I think it captured up on ITVX, but I think there was a documentary on there on over-the-counter issues in the UK, and they couldn't provide the exact data, but from the research they'd done, they stated that there could potentially be 10 million people walking headfirst into addiction from over-the-counter analgesia. And I just think it warrants further investigation. You know, is this adding to that, or is it causing people to divert when it's not done correctly? And the evidence that I'm seeing with referrals on a more regular basis now is that, and the conversations I have with patients, is that is what they are doing because of, you know, how it's been managed.
Okay, thanks, Paul. So unfortunately, I think we're going to have to draw the session to a close. We'll have a look afterwards at the chat and see if there's anything that we've missed. And as I said, we will try and follow up if there's any big ticket items in there. We definitely will share the slides. We will share the full evaluation report and the video case study as well, and contact details as well. So, you know, we're open to further conversations about this. We'd love for you to take this forward and help us to spread it as a new way of working. I think it's really a blueprint for a new pathway. And, you know, the collaborative working, I think we've proven that, you know, in an area of need where other interventions have maybe struggled to have an impact, it works. And I think that's because at its core it's that framework for stronger human interaction, bringing everybody's skills together to support people in the way that they need it when they need it. So sort of regardless of the funding, it would be great to have some spread and progress with this. So yeah, my parting message is, yeah, go and do it if you can. Get that collaboration going, get your heads together and see if you can create a similar shared approach in your own region. So yeah, please do get in touch if there's anything else that we can help with. And just remains to say thank you to everyone for joining us. Thank you to all the speakers. It's been an absolute joy working with you all over the last couple of years on this work. Yeah, so thanks again from me, and enjoy, well, hopefully enjoy the evening when it cools down a bit. Yeah, go and get a cold drink of water, and we'll leave it there. Thanks, everyone.